Okay. So YouTube live है? YouTube live है? Okay. So good afternoon, everybody. Huh?
India, we can hear you well. Okay, but we won't start now.
Hello?
Yes, India, we hear you.
ये कौन है?
India, can you hear us?
Yes, yes. Can you hear me?
Yes, I hear you.
Yeah, Dr. Natarajan here.
Hello, doctor. How are you?
Very good, very good. So
We
whenever you
are
are
just adjusting some technicals,
right,
and we will go back to you.
okay, okay, no problem. I can see Fabio. Hi, Fabio. Okay, YouTube live क्या कौन कर रहा है? ये म्यूट करने का ना?
Dr. Fabio, can you hear us?
I can hear you. Yes. Yes.
Dr. Fabio?
नहीं, ये लोग का म्यूट करने का ना अभी. ये अलग है. हम क्या बात करते हैं अभी क्यों सुनने का? आ रहा है वॉल्यूम?
Dr. Fabio, can you hear me now? Okay, I can't hear you. Can you check your mic?
He's telling about the patient.
Samir,
Hey, what about Jaydeep? This is my Jaydeep. आएगा ना? Now he's coming. Okay.
Right. Good afternoon, everyone.
Well,
It's
later,
a great pleasure to be a part
Samir
of
has
this
credit all
meeting,
this.
the Cairo Retina Meet, and we are going to do a live surgery today. And This is the center in India at Aditya
India, we
Rai
didn't
Hospital.
start yet. We didn't
So,
start yet.
my name is Dr. Jaydeep. I'm a vitreoretinal surgeon working with Dr. Natarajan. It's a great honor to represent him today. I'll be briefing you about the case that we are going to operate
India.
today. So, I hope I'm audible.
India, can you hear me?
So,
India, hello.
this is a case
Hello.
of proliferative diabetic retinopathy. And we are operating upon the left eye of the patient who has a tractional retinal detachment along is stable. So the left eye is
India,
having a
please.
counting fingers at 1.5 meters, and he has a tabletop tractional retinal detachment over the posterior pole and her macular hole along with it. So this is a very challenging case when it comes to VR surgeries, and I'm sure Dr. Natarajan's expertise is going to be tested here. So we are all ready and we'll be starting shortly. So as we start, we are going to show you some details of the case, and then we'll proceed with the surgery.
Hello, India. Can you
Just
hear
give
me?
us few minutes so that we can get everything organized, and stay tuned for the updates. Thank you.
Hello, India, can you hear me? Hello. Hello, India.
बंद केलं उलटी म्हणजे बंद केले
Okay.
माझा आवाज आला का
Ça, si on met ça, il faut changer quoi donc ça, c'est une lentille 200. Ça, c'est une lentille focale 200. Ok, ça. Donc ça, je dois changer. C'est avant la chirurgie, tu me dis, je change, ça me donne 5 minutes de travail. Ça me donne ma distance de travail. Et hier, il a dit, je m'en fous. Et soit 20 cm, soit 10,5, parce que le rapport au net, avec la différence.
C'est une simple chirurgie.
Stop, Herbert, Paul. J'ai fini le 17 octobre 51. Voilà. J'ai venu pour le docteur Bali. C'est pas pour quel chirurgien vous êtes là, monsieur? C'est pour le docteur Bali, le chef de service. D'accord? Oui. Vous allez être opéré de l'œil. De l'œil. Dites-moi, gauche ou droite? Gauche. Gauche ou droite? Gauche. Gauche. Est-ce que vous êtes allergique à quelque chose? Non. Est-ce que vous êtes à jeun? Oui. Très bien. Vous n'avez pas de dentier? Non.
Soulevez les épaules, encore, faites des abdos, encore un peu.
Voilà, détendez-vous, tout va bien se passer. D'accord? J'ai fait. Oui, oui. Oui. Tout le monde me voit? Ouais.
Good morning, Germany here. The doctor is ready in a few moments.
Ouais, papa, c'est pas grave, c'est pas grave.
Elle est 10 minutes plus tôt, sans être payée.
Voilà, monsieur.
C'est toi qui gères, en fait.
Ouais. Ouais, bon. On va prendre une tension, ça va c'est. Voilà, moi je suis prêt. Expiration. Oui, oui.
Pierre-Marie, regarde un peu le 16. Pierre-Marie, s'il te plaît. Regarde un peu dans le, si c'est bien le 16.
C'est bon.
Oui, il veut les mots.
Ouais, c'est deux, oui, oui, c'est ça. Et deux rouges par point. Voilà. Non, c'est le côté. Que j'avais écrit là. Vous allez prendre
Yes.
Faire ça tout doucement à notre aide. D'accord, monsieur Top? Voilà. Tout va bien. Fermez les yeux, monsieur Top, respirez bien fort. Très bien. Bien, c'est top.
Wieder zurück. Mhm. Gut, dann starten wir. Mhm.
Amir is saying,
Mhm.
let's
Ja,
from
genau. Ja, ja. Und wir starten mit deinem Bild. Wir
only then
starten mit deinem Bild.
ठीक है, what
Mit
am I?
deinem Bild, nicht mit dem Mikroskopbild.
he's
Tell-
putting a message to them that
No need, no need. No need. Tell him.
Ja, können wir die Armlehnen, einmal die Armlehnen einen Tick höher, kleinen Tick nur. Mhm. Mhm.
Jetzt die Frage, oder das ist wieder der Frage. Oder? Man kann auch so ein Bild stellen, als geht bei uns schon sieht man es immer. Das geht, und kommt dann aus dem Bild. Ich habe hier jetzt mal gestartet. Ne?
Folienschere. Wasser. Mhm. Gut, wir können. Ist unser Bild jetzt drauf, dass die uns sehen? Sie achten auf die Zentrierung, ne? Ja, gut. Ja, genau. Wir machen das Licht jetzt an. Nochmal Wasser drauf. Hm. Tonübertragung ist auf dem Handy drauf, ne?
Also das sind
Herr Klein. Ton ist drauf, ne? Ich kann, aber auch wenn ich spreche, wird es übers Handy aufgenommen oder übers Headset. Okay, gut. Müssen aufpassen, dass sie nicht austrocknet. Hm.
so ein bisschen Fisch hast du drauf. Man sieht den Cloud runter, also oder nur dein.
Also, du machst, wie du es für richtig hältst. Sieht auch schon professionell aus mit dem Touristenstick.
Voll der ist.
Okay. Haben wir eine Tonprüfung oder brauchen wir es nicht mehr?
Ja, das schon gehört. Also nur im Moment redet keiner was von dem.
Gut, weil es ist 8 Uhr.
Ja.
Fragen Sie den doch mal, wann es losgeht.
Okay.
Recommended.
Because Samir messaged them, they have not replied. My mic is on.
My mic is not on. Sister, clean the lens. Sticker, remove the biome. बराबर नहीं ठीक है देखो remove the sticker डालना remove the biome light on sticker डालना पड़ेगा helmet tooth forceps yeah scissors
Good morning, Cairo. Sulzbach is ready.
hello
Good morning.
morning who's speaking yeah here Dr Natarajan here sticker tooth forceps
Das wird nicht Spaß. Wer hat sich gemeldet?
this one use that water cotton but eyelashes coming water bag bowl here with the saline sticker money
Ask them.
you can ask them you can ask
Good morning, Cairo. This is from India. We are ready with our surgery. Whenever you give us a green signal.
Same for Sulzbach, we are ready.
AC temperature you can ask them that I'm operating. Yes, send microscope turn करो ऊपर करो microscope ऊपर करो यार centering करो
Das machen wir auch.
centering
Kurz auf das OP-Video umschalten. Ja.
Jaydeep,
Good morning, Cairo. We have started with Dr. Natarajan has started the vitrectomy. So whenever you say start the
Fabio, you can hear me?
Handy.
Wir machen nochmal Handy. Aufs Handy schalten. Ja.
Right. And check with the where is it? This fellow? Rohan Gidra.
He's here, sir.
No, can you just check with Samir? Are they seeing this in Egypt? Give me the steroid.
Good morning. Welcome to the Cairo Retina Meeting. It's a pleasure having you all with us, and we look forward for a great day. We will start the day by the live surgery from 9 till 11. Then the rest of the program will go through, and the rest of live surgery will be back again at 4 o'clock. We have more than 12 countries participating in the live surgery, so we'll have different locations all over the world. Surgeons, Dr. Kouros will read them for us in a minute. At 3 p.m., there'll be the lunch with the experts, roundtable discussion. So I encourage you to register now to the table that you want to assign with. Will be at 3 o'clock for lunch. So you can assign that at the registration desk. I give the podium now to Dr. Kouros, and I have to thank all our sponsors for the live surgery: Dork, Alcon, Tito, Novartis, Bayer, all the great sponsors that were behind this great meeting and helped to put it all together. Also BBI, I can see with us here in the room, so they also participated with a great deal in the live surgery to have it all to the standards. So enjoy the live surgery. There will be a discussion during the transmission with the panelists here. Of course.
Great. Thank you, Hab, and congratulations again for the fantastic 2023 Cairo Retina Meeting. My co-moderators are Dr. Klaus Eckhardt from Germany and Ehab himself from Egypt. Surgeons are Ernesto Bali from Belgium, Fabio Patelli from Italy, Peter Stallman from Belgium, Peter Schurman from Germany, and Sundram Natarajan from India in the morning. And we have a fantastic panel here who will participate in discussion. Dr. Daniel Tonito, Geroni Nadal, Kazuaki Kadonosono, Mario Romano, Khalid Al-Sabti, Alafati, and Sunil Garg, who have joined us this morning. So can we move on to the rooms now? We can go start with Fabio. Fabio, can you hear me? Room 2. So, Nati, can you hear me in India?
Yeah, we can hear you.
For us?
Okay, Nati, so good morning.
Morning.
So your case is a traction retinal detachment with macular hole due to proliferative diabetic retinopathy. Is that correct?
Correct. Correct. Correct.
So can you walk us what you're doing now?
Yeah, right now I actually started the vitrectomy with a 3-port pars plana vitrectomy, and I use the old night eliminator from Dork. I used the steroids to stain the uncut vitreous. So now you can see some amount of the posterior the vitreous. I'm just cutting it.
Nati, what instrumentation are you using? What kind of a machine and what kind of a lens and microscope?
Yeah, you can show the actually my camera to the Dr. Jaydeep. So I'm using the constellation. I'm using 10,000 cuts. I have at present kept the section at 600 with a linear control, and I'm using twin light from actually made by Dork in the past, but now it is connected with the constellation.
Wait, can we switch to surgery view so we can actually see what you're doing?
Okay, can you show the surgery?
TV machine and
The IT team. No, the camera view. Funders, what do you call that? the microscope view.
Hmm.
Now,
Dr.
Jaideep,
Sapna, can you?
they have to put the full screen on that.
Yes.
No, they want to see the OT, the screen.
Yeah, I'm just asking you to see.
No, not this one. They call what I'm doing there OT.
The
So
screen
let's go now. Thank you, Nati. Can we go to room 3 now with
That is-
Peter?
is there.
Okay.
Peter, can you hear us?
We have to show.
Okay.
He is focusing on you. You
Oh.
want to show the alcohol
Yeah,
machine?
that's what they wanted to see.
Peter, can you hear us? I think Peter has an optic nerve pit maculopathy. We can see the optic nerve pit here.
Yeah. Good morning to Cairo from Sulzbach. Nice to hear you. Yes, we have an optic disc maculopathy. It's a 64-year-old woman. She has been operated with standard technique with laser and long-term gas tamponade 3 months ago, but it failed. And now we are doing an amniotic membrane plug to close this pit. The good thing is that this pit is clearly visible. Sometimes there is not a real hole, but in this case, it's a clear hole, so it can be closed with an amniotic plug. And we are doing surgery with an EVA using the new Avitotrocars from Dork, and I'm assisted by Dina.
Great.
Umschalten?
Klaus, any comments from you?
Nein. Umschalten.
The
Ist
status
das
of
Mikroskopbild
the
drauf?
lens is still faking, Peter?
Yes, the lens is still phakic, and it's still clear, although 64 years old.
And this is the second surgery, is it right? Yeah.
Yes. Yeah. Maybe without live surgery, I would have done the cataract now, but I prefer not to combine it to have more time for the interesting parts of the surgery.
This hole, what we see in the periphery. No, sorry, this is a different case. Sorry.
So it's already vitrectomized, and we are punching now the amniotic membrane. Licht an, Licht an.
Yeah. And how do you choose the size of the amniotic membrane, Peter?
Good question. For epiretinal amniotic membrane, we use 6 millimeters, and for the amniotic plug, we use 3 millimeters. I've tried 4 millimeters, but even in large pits, it's too large to stuck it in this hole. But 3 millimeters is still large, but it's possible to put it there. But again, it's only possible, this approach, if there is a clearly visible pit.
Klaus, you wanted to comment?
What kind of instrumentation, what gauge do you use?
Our standard is 23 gauge, but the question is good because to bring the amniotic membrane in, we use this 27 gauge end gripping forceps.
Yeah.
So 23 gauge trocars, but 27 gauge forceps. So there is enough place to introduce the instrument and the amniotic membrane.
Peter, does it matter which side of the amniotic membrane you use?
So again, as large as possible, but
No,
I've
not the
tried
size, the side. Is it the front or the back?
No, because it's a plug, so it's really stuck within the pit. So there is no side. It will be just pushed inside. And we do the fluid air exchange now.
Peter, most probably this is not the only way with which you try to close the hole or the pit. What is the reason that you switch now to the amniotic membrane? Most probably you have also tried different materials.
Yes. So first surgery was different. where we used our standard technique, but I think we all agree that the standard techniques with long-term tamponade and a subthreshold laser and maybe aspiration of subretinal fluid, it is quite disappointing, and the success rate is less than 50%. Sometimes it works. In most cases, after 2 or 3 surgeries, it's possible to close it. And the few cases with amniotic membrane we have made, there the results seem to be better, but we need more experience to find out which cases are perfect for this approach.
How much do you wait between surgeries, Peter? If the surgery has failed, how much do you wait to make the determination that the surgery failed and go to a re-op or a second surgery?
In this case, we have waited 3 months. I think this is a good time. Some cases after laser, they have an improvement, but not a complete cure of the situation. And in those cases where nothing happens, there is no reason to wait for months.
So now you just remove the valve so you get the amniotic membrane easier through the trocar, correct?
Right.
While he's loading, I'm going to ask the panels quickly. What is your technique for closing the optic nerve pits? If you just tell me, how do you close it? Sunir, while you have the microphone, how do you close it?
Yeah, I'll still traditionally do a standard surgery where I'll use a PVD. A lot of times I'll do an ILM, use that over the hole, laser around the edge of the hole, then put in a gas tampon out of a few days of face down. But in cases in which it doesn't work, I've been putting material, whether it's to the plaque or amniotic membrane, in the hole. And in the few cases I've done, it seems to work pretty well.
Solid.
Yeah, I'll do the same. I'll try, start with the large island flap, put it over the bit, and it worked very well. I started doing this 20 years ago, where initially we used to use the TCM glue, and I have publication in that TCM glue, which did work for at that time, but I think the island flap would be the safest way to do it right now.
Peter, what are you doing now? Peter, can you hear us?
So I repeated it, and now I have a nice piece of amniotic membrane. It's over here.
Why did you repeat it?
I didn't find it on the punch. I don't know where it is. Maybe it was adherent to the punch itself. So this amniotic membrane is typical sticky, and it adheres to the forceps. So you have to release it first, and therefore it's good to have a very small water layer on top, and then you can release it.
So you never do it in a bimanual technique, Peter, is it right?
Not in this case, no. I mean, I've my light pipe as a second hand. This is enough. In diabetic patients, there I prefer bimanual sometimes.
We can see it's stuck to the forceps now. Klaus, do you usually do bimanual?
Yeah, I think so. I would prefer to, but I must admit, since 2 years I haven't done it. I did not have the case. I don't know, but most probably I think it does not stick only to the instrument. It also sticks to the interface.
So now, so Peter, now it's released. Now you have to put it in the hole, I guess.
Yeah, right. I reduce the water layer first. You can see on the OCT image that we have a real large subretinal fluid layer in this case. Sometimes the fluid is more intraretinally, but in this case it's also subretinally. But we have aspirated in the first surgery the subretinal fluid, and it is worthless, because if you don't cure the underlying cause, then the subretinal fluid will come again immediately.
Peter, there is sometimes, at least to my experience, and it's also noted in the literature, there is some material, remnants of vitreous or something like that inside the pit. You try to remove it before you or are you thinking that the first surgery has already done it?
Yeah, very good. And you're absolutely right. There is often a vitreous plaque. And during retinal detachment, it's mostly removed, and we are looking for it actively. But here in second surgery, I think there is nothing to do.
So while he's manipulating, so the pathomechanism of a optic nerve pit maculopathy in general is the hyaloid pulling on the plug on the optic nerve pit that works like a vent. And you want to release that traction, as Klaus was pointing out. So induction of PVD is extremely important. And we have seen videos where people spend a lot of time actually trying to dissect inside the pit, which I don't know how beneficial that is, because you probably cause secondary damage to the optic nerve. And now we go to the critical part of sticking this into the optic nerve pit without getting stuck to the forceps.
Can I ask why you are doing this maneuver under air, not under DSS?
It's flying away. And the air has the advantage that it helps to push the amniotic plaque inside of the hole sometimes. Here it seems to be quite resistant.
It's because it's live surgery. Mario, great point. My thought was because it would probably float around, so you want to prevent that from.
But sometimes it's not easy to manage, because if in the water it can stay a little bit, floating, and you can easily manage. And sometimes taking a touch even more.
So let's go now to room 4 while Peter is working on this. Ernesto, can you hear us?
I can hear you very well. How are you guys?
Great. So would you tell us what you're doing now?
So this is a 71-year-old male with a long-standing retinal detachment. Basically, he didn't go to see his ophthalmologist, so he came with a total detachment PVR. As you can see, macula is off. So we have a bit of a PVR everywhere. We can see a PVR here. I think there's something there on the macula. After I'm doing a whole shaving, which I'm really carefully, you see here, there's already a fold between the ora serrata and the retina. So I really gonna shave all this part very, very well to make sure that, I don't know if you hear me with the sound of the machine, it's quite noisy. You see all this, because if we have to be careful to remove all these tractions here, otherwise it's a sure recipe for a redetachment and a more severe PVR inferiorly, which might need a retinotomy. I'm going to try and do everything I can to mobilize this retina as much as I can to avoid the retinotomy at this stage. But there are holes a bit everywhere, holes here.
Ernesto, what instrumentation are you using?
So I'm using a Dork, the Nexus, the new machine from Dork, the Nexus EVA. I use it sometimes in and out, and I think it's a quite great machine. But I suppose Peter Salmons is going to come in, or Klaus next to you, which has way more experience than I have with this machine, can tell you all about it. And then I'm using an Artivo 3D, which I find really an excellent image.
Great. Let's go to room. Thanks, Ernesto. We'll come back to you. Let's go to room 2 now with Nati. Nothing, can you hear us?
Yeah, I can hear you. Can you hear me, Cross?
Yes, we hear you great. So what are you doing now?
I've actually removed all the membranes. I did a bimanual dissection, and you can see some blood there. Yesterday, I gave an anti-VEGF injection to avoid this heme. So I'm now going to do a fluid air exchange to do an endodrainage to the peripheral breaks.
Nothing. My understanding is this patient had macular hole. So you're peeling the ILM in this patient?
No, right now, what there is a macular hole, but also there are peripheral breaks, which I saw. I've done the diathermy, and I'm actually going to do a fluid air exchange to see how the retina is going to settle.
Great. So let's go to room 1 now to Fabio. Fabio, can you hear us? Can we go to room 1?
So this is the one who gets an encircling element.
Klaus, what material do you usually use for these cases for skull buckle? Do you do buckles usually in these patients? Is an inferior detachment?
You mean if I kind
Do
of
you usually use scroll buckle for an inferior detachment?
if I really see PVR, and if this is obvious here the case, I would like to have an encircling element. Yeah, this costs 12 minutes or so, and I think it's worthwhile doing it. Otherwise, you end up and have to do retinectomies, and I don't like retinectomies.
What element do you usually use?
3 millimeter.
3 millimeter. Can we go to room 1? Can we get him? He's calling. Sounds good. So let's go back to room 3 to Germany, see how Peter is doing with the optic nerve pit.
Yeah, it's still not possible to introduce it. I've looked, like Klaus has proposed, if there is a vitreous plaque, but I can introduce the forceps in this hole. But the plaque itself will not prevail within. So if I stuck it, it comes out again. And I've dried it 3 times now. So it's well visible that under BSS, it doesn't work. It works only under air in my hands.
Any comments from the panel? Any suggestions? Obviously, it's difficult to get this in to the optic nerve pit, Klaus.
My neighbor said just perhaps it's too big. And of course, in former years, I used sclera. And I remember one case where I really have to press it in even after I shortened it or make it smaller. And of course, I really was nervous to exert some pressure on the optic nerve fibers, but it was well tolerated, I must admit. And of course, if you have a visual field defect post-operatively, you never know exactly what it also before the surgery is the case. But obviously, there is a certain risk if you have a plaque with it too big. Maybe that this risk is smaller when you have this soft material like amniotic or ILM compared to sclera. But I was quite successful with my cases. One case I lost the sclera plaque came out after 2 years only. But,
one of the things
Sentite
also,
adesso?
the chorus is the size. When it's too big, it's likely to dislodge once you go to fluid. So
Oops, sorry.
sometimes you need to tailor it in the eye, and the smaller it is, the likely it will be in place. The larger it is, the likely it will dislodge.
I think also manipulation is hard under air, you know, and it's sticky, so easier said than done. So let's go now to room 4 to Ernesto. Back to Belgium, and let me know.
Ok, mi sentite adesso?
Okay, we go to room 1 now. Great, we have room 1 available.
Okay, can you hear me now?
Fabio, we can hear you great. How are
Okay,
you?
sorry for that. So this is a case of 59 years old man who had a retinal detachment, recurrent retinal detachment in the other eyes also with a bad PVR. So in this eye with vitreous hemorrhage and inferior break, I decided to put an encircling buckle
Also because the vitreous base of this patient is very bad, so I'm sure I cannot remove all the vitreous base. For this reason, I also use this kind of buckle. It's a 5 millimeters oval band that I always use in these cases, because it's protect and they contract all the vitreous base. So I couldn't see the break because for the vitreous hemorrhage. So for me, it's a surprise. I don't know if there is a big break or a small break, but anyway, I don't know if you agree, but I think the scleral buckle in this case is safer than only vitrectomy.
So this patient did not have PVR, but you were
No,
just
but he had PVR in the other eye.
the other eye.
Yes.
And Fabio, when you put the infusion line, do you first check where the trocar tip is in the eye before you open it, or you just go in?
But yes, it depends on the cases. Yes, sometimes yes, but I'm quite sure that the retina is not bolus in this case, so I'm quite safe to insert the trocar normally. I use the chandelier in all cases with the valve trocars because I do a self-indentation, so I prefer to use a chandelier in all these cases.
And you insert the buckle before you start.
Yes, yes. Correct? And then I fix the buckle under PFCL.
Under the tightness of the buckle.
Yes, because without trocars, it's better to fix, to pass the buckle when the eye is closed.
Quick question for the panel. Do you do vitrectomy buckle if the other eye had PVR in the past? Daniel?
No, I don't. If we have an inferior PVR, I agree. I put a buckle,
but not in the other eye.
If not, I don't put the buckle.
Kazuaki, you're very quiet. How do you do it?
Most of the cases, I routinely use the buckle. And
what about PVR in the other eye? Not in this eye.
Yes, I prefer buckle.
You do buckle as well. Klaus, you?
Thank you. Depending on the degree of PVR.
PVR in the other eye, you mean?
Huh?
PVR in the other eye.
In the other eye, no.
This eye does not have PVR.
No. Then I wouldn't do it.
Then you would not do it.
But for example, if it's a break like this is quite a large break here.
Mm-hmm.
Yeah, I think a buckle would be quite okay. But I have another question. I know that you also do sometimes heads-up surgery, yeah, 3D surgery. Is it so, or are you not a head-up worker?
Fabio, what is your setup?
Fabio?
But I know he has constellation based on the markings, but I don't know whether he has a.
Can you hear me?
Yes. What is your setup? Can you go over your setup with us?
No, it's this is not a 3D head-up surgery, but because I don't have it always in my OR, so in this case, it's not a 3D. But when I can, I use it.
My question was, when do you use it? When do you use it?
When I have it in my OR, because the hospital didn't buy it. So sometimes the outcome brings it to me, and when I can have it, I can use it. In private surgery, I use it always.
Okay.
Let's go to room 4 now. Back to Ernesto.
So I'm really doing the whole shaving here. And because this is, I think, in a case like this, it's really the mandatory step to
Ernesto,
avoid.
do you put buckles in these patients?
Say it again?
Do you put a scleral buckle in these patients?
No. I heard your discussion. No, I never use scleral buckle anymore. In none of my patients if I do a vitrectomy. If in case he's going to develop a very severe vitrectomy, a very severe inferior PVR, I tend to do more retinectomy instead of a buckle.
So you see a big spectrum just by this surgery. In one room, we are putting a buckle because PVR was in the other eye. Here we have PVR, but we are not putting a buckle. And that's just the beauty of retinal surgery, that everybody does it a little bit differently. But that just shows you the spectrum.
Yeah.
But as Ernesto pointed out, it's extremely important to do a meticulous shaving to make to reduce the likelihood of a redetachment. Khaled, what do you do in these patients? When do you put a buckle in a detachment?
That's okay.
Certainly this I'm gonna for sure.
Dr. Fatih, you?
Yeah, I stopped doing buccal a long time ago. In such a case, I put retinectomy and then I put BFCL. I leave it there for 2 weeks and then remove it after laser is going on.
Any problems with inflammation or residual perfluorine bubbles if you leave them in?
I always maintain the patient on low-dose systemic steroid and topical steroid. In the very beginning, I had such deposits on the back surface of the lens and inflammation. But if you use systemic steroid in low dose 20 milligram per day for 3 days and topical steroid, you will never have inflammation.
So let's go back now to Fabio, room 1.
Yes.
So you have this large break, Fabio.
Yes.
So it looks like you removed the anterior flap. Is that correct?
Yes. And this is you see a round edge of the break. So I try to, I'm gonna clean the vitrus, but now in a few minutes I will put perfluorocarbon just to stabilize the macula and continue the shaving of the base. But you see the vitrus here is very attached to the retina, to the peripheral retina, very attached. So when I go with the vitrectomy, the retina comes in the vitrectomy mouth. So, and this unroll edge, I will try to unroll.
I guess you have to unroll it when you put the perfluorine in. What instrument? Well, I guess we're going to wait and watch how you do it.
What instrument for what? Sorry.
I was saying, what instrument you're going to use to unroll the edge?
I have finesse. I have the finesse.
Finesse flex.
I have the finesse. Yes.
So let's go back to room 3, to Frank, to Peter Sherman.
Yeah, we're still trying. I have recapped the trocar to have a more stable air infusion. Sometimes the air presses the membrane inside the break, or inside this pit, but in this case it's not. And I will now switch to bimanual by using a chandelier light and then a second end gripping forceps.
Great. So let's go back to room 2 to India,
Yeah,
to Nati.
Yes.
So, Nati,
Yeah.
can you hear us?
Yeah. So I can you hear here? I've completed the removal of all the membranes, and I'm doing the PRP. For the macular hole, I'm only doing an endo drainage through the peripheral break and keeping the retina attached. And I'm going to use the silicone oil as a tamponade. And Class A card was asking about head-up surgery. I use the RTO 800, which is there in the operation theater, and I use it regularly. So I use the RTO 850. And here I'm using the twin light chandelier, which was introduced by Class A card. And maybe I can remove the microscope, show the twin light, remove the bio. So,
What kind of a tamponade do you usually use in these patients?
so I'm going to use silicone oil. So this is the twin light, I think, where you can see the twin light designed by Class A cut in probably the 90s. And I still preserve it, and I'm using it as a 2 trocar, and I'm putting this twin light. And right now it's with the air on, light on.
Thank you, Nati.
Yeah.
What kind of a tamponade do you usually use in severe diabetics?
I use silicone oil.
What are you using, Nati, again?
Silicone oil. Silicone
You use
oil.
silicone oil. Great. So I was just asking the panel.
The kind of tamponade. What is
Yes.
your question? The tamponade, of course. Well, I try, of course, to get along without the use of silicone oil, but it's depending on the patient also. If I am really, if he tells me he can have a certain post-operative positioning, then of course I trust him and try first with SF6. Usually I don't use any other guards, only SF6, because I think the first 6 days are most important, and I do not want to have a longer way. If the retina then detaches, then I of course switches immediately to oil. But what kind of oil is the more important question. I use very often Denzirone oil with good success, and all these stuff, all these complications which we had with other oils in the past or with other heavy oils, I don't see anymore. Emulsification is not a problem at all anymore.
Sunir, what is your tamponade agent?
It depends on the case. We'll have SF6, C3FA, and then oil. These cases, I cannot say that I have one particular way that I do things. You know, the very ischemic eye, there's a lot of breaks in different locations, but it looked like Dr. Natarajan did a great job relieving traction. As long as there's not residual traction, I'll still feel comfortable putting in gas rather than oil.
Kazuaki?
Yeah.
And in the meantime, thank you, Nati. We're going to go to room 1 now.
Okay.
Thanks for beautiful surgery. Kazuaki,
you.
what is your tamponade choice?
I recently like using the silicone oil because in order to decrease also the sudden accidental bleeding.
Because I'm the only one who likes C3F8. I use C3F8 only in the diabetics. So
Here we
Fabio,
are. Yes.
how are we doing? You're putting perfluorine in?
It's doing fine. It's doing fine. I rolled the edge. I rolled the edge of the break, and now I'm going to put some vitreal S just to visualize the vitreous base and try to remove the vitreous mesh as much as possible. You see here the vitreous, how attached is to the retina, and try to pull it, but it's really strongly attached. That's why I think in these cases, a buckle is safer. It's not a wrong choice. You see how is attached. So it's very difficult to remove the touch this kind of vitreous. So yeah. I think that in this case I will put Denzirone because of the inferior breaks, but the buckle protect me all the vitreous base, even the upper part of the eye.
I think you have a very posterior vitreous base, and that makes it
Yeah.
challenging. With
Yeah.
this large size of a break and macula being off, any concerns about getting subretinal perfluorine, or do you do anything to prevent that from happening?
Yeah, I have to release the vitreous, to release the retina from the vitreous. Then when the retina is free, I don't think when I inject the perfluorocarbon, I used to aspirate with the vitrectomy with the other hand in order to not create bubbles. So if you have only one bubble, it's difficult that PFCL goes under the retina. If you have multiple bubbles, the risk is very high. So that's why I want to create different of pressure into the eyes while I'm injecting perfluorocarbon. I aspirate with the treatment, inject perfluorocarbon, and so usually it doesn't happen. But who knows? Maybe
You never
I have to be careful.
The vitreous with the triamcinolone, or is it only that you do it?
No, now I'm going to use a vitreal S that is it's like triamcinolone. But
Fabio.
first, I want to detach the vitreous.
Fabio, Mario speaking. So great job. I also agree to put a buckle because the vitreous base is so large. But the point is, because now the retina break is so big, you can have the buckle, the encircling band that is, in the middle of the.
Okay, I understand.
So
exactly.
You can have a meniscus under oil then.
Yes, but this kind of buckle, the indentation is very soft. It's not very strong, so it doesn't create a curtain. It doesn't create a scaffold for the proliferation, because Denzirone can push the retina, and you will see that usually at the end this buckle is very soft, the indentation. So I don't think it's going to have this kind of problem that you are talking about right now.
Thank you, Fabio. We're going to go to room 2 now. Peter, hello to Belgium.
Good morning.
Hi, Peter.
You can hear me?
We can hear you great.
Okay, excellent. Good. Today I will show you a case which I will operate with the new DORC-EVA Nexus system and visualizing it with the Zeiss Artivo microscope. We can switch to the microscope view now and maybe dim
Can you
the
tell
light.
us what kind of a case you have?
Yes, the case is a gentleman who has an implant for about 10 years now, an IOL, and he keeps having recurrent vitreous hemorrhages. I think he had on average one a year, and we never found why they occur. Till he came a few months ago with another recurring hemorrhage, and then we decided to have an ultrasound biomicroscopy done. And maybe you can show the PowerPoint slide that I gave you earlier. There's the UBM picture on it, and you will see that there is contact between the front of the IOL and the rear of the iris. So there is iris chafing, and this is most likely the cause for these recurrent hemorrhages. So what we will do in this case is do a vitrectomy, cut the IOL in 2 halves, remove it from the eye, and implant Carlevale IOL instead. And that will hopefully cure him from his problem. I was just admiring in the anterior chamber, I'm not sure if you can see it through the transmission, you still see these ghost cells floating around in his anterior chamber. So these are whitened red blood cells now. So his hemorrhage is almost resorbed, but I'm sure that without treatment, he will have a new hemorrhage. You also see some red blood cells in the anterior chamber, which indicates a more recent hemorrhage. So there's a continuous process of bleeding and resorption of the blood cells. I have the overlay turned on, so on my microscope screen you can also see the parameters of my surgery. That's a new feature also included with the Nexus system. So I will now open the conjunctiva, install the cannulas, prepare the flaps, which I will use to for the IOL implantation, and then proceed with the vitrectomy.
We'll come back to you, Peter. Thank you. Let's go to room 4 now to Ernesto.
Hi guys. So now I'm peeling the ILM here because you see the macula, even after injecting the PFL, is totally wrinkled. So definitely some traction. I didn't have a fantastic coloration, unfortunately, but I might color back. But I can see, I can appreciate. Here we already did a peeling. Here we peeled already a bit, but here there was more tractions. We are almost out of them. I think there's more tractions here I have to take away. You can see all this wrinkling here. But I'm
Ernesto, do you usually peel the ILM in these PVR patients?
No, I color them. I see how it is. And if it's necessary, I peel. I tend not to do any unnecessary surgery. I mean, I don't peel just because no.
When do you make a decision that it is necessary?
Huh?
After staining.
Yeah. Thank you, Klaus. The staining, exactly. The staining, the wrinkling, and I had a better staining before putting PFCL. But then
with what did you stain?
Yeah, I stained. They gave me ILM ILM blue instead of the dual blue. Unfortunately, they're stressed. You know, the guys in the room, they're very stressed because you're all there. I'm joking. So anyway, I got a, you know, unfortunately, this is real surgery. It's not right surgery, so I got the wrong. But I stained again with another blue, but unfortunately, still didn't get enough staining.
You mean dual blue?
Yes, I got dual blue afterwards, but I didn't get enough staining either. Maybe I didn't keep it in long enough. But I think I'm pretty much. I'm pretty much. Sometimes the patient, even if it's on general anesthesia, he ticks a bit. Anyway, I think the macula looks pretty open now. I had a few folds there and there. I think I don't know if you have a good image with the Artivo. I think here the macula is really impressive. The image you can have at such a high magnification.
I think you should leave the macula alone now. It looks pretty good.
Yeah, exactly.
Did you see pre-operatively any membrane on the macula with the OCT?
No, not really. You can really appreciate it. We saw the OCT. The macula was definitely off, but we can really appreciate hugely hugely a huge macula. On this, unfortunately, on this Activo here, I don't have an OCT module. So now I couldn't go in and have a look with the OCT, but I would have loved to if I had one. But
Thank you, Ernesto. Let's go to Germany, room 3 with Peter.
Yeah, still struggling. I had it half in, but only half, and now I'm drying again. So manually it works a little bit better, but still, if the plug doesn't want to get in, if there is no space or any obstacle, then it doesn't work. We're trying.
Peter, we have a question from the audience. Could perfluorine help with manipulating the and stabilizing the graft into the optic nerve?
Yes. Indeed, this is the next step and the last step. So I'm waiting until half of it is inside, and then I will try to stabilize it with PFCL.
Oh yeah.
Let's go back to room 1 now with Fabio.
Yes.
So you are doing some beautiful vitreous shaving.
Yes, I'm self-indenting. That is the best way for vitreous shaving, in my opinion, because you know how to indent, but you see the vitreous is very attached here. So I always, every minute, more convinced that buckle is necessary in this case. You see how it attaches the vitreous. So even if you put dancing on, you have problem in the upper part of the eye. If you put normal oil, you have problem in the inferior part. So the contraction of the vitreous base due to the buckle, I think, is necessary in these cases.
The posterior hyaloid is separated, correct?
Yes, yes.
This is just a very broad.
It's very large vitreous base attached to the retina. You see how, and also I think also that in these cases it's mandatory to visualize the vitreous with the triamcinolone or Vitral S, because otherwise you cannot see all the vitreous very well.
Just going to ask the panel quickly: do you stain the vitreous during vitrectomy?
Yeah, sure.
What?
The point is if using triamcinolone without alcohol or with alcohol. And then we know that still using without alcohol, there is some toxicity, there's some interaction. So, but basically I'm staining.
Khaled, you stain?
No, I don't frequently.
Sunir, you stain? Very frequently. Daniel?
Yes, I stain triamcinolone, but in this case, Fabio has a very posterior
vitreous
space, so the traction are strong. So I think that in this case it was right to put a point. Okay.
So we have 2 Italians on the same side, which is good. Klaus, do you stain vitreous?
I stain always the vitreous. By the way, the question should not be, should we stain the vitreous, Donan, but should we stain also if there is no retinal detachment?
Well, in this case,
usually, always.
Well, I usually never stain, so for me it doesn't make any difference.
I always stain with triamcinolone.
Kazuaki?
I don't think it's necessary to have stain.
It's a beautiful panel. I like it.
To shaving.
Another thing that I used to do is to remove the vitreous at the edge of the break. You see, I do diathermy and then I cut the vitreous. I think that everyone does it in this case. I don't know if the panel agree with my decision.
Great job, Fabio. Looks beautiful. So let's go to Peter now. Peter Stallman in room 2.
Yes.
Belgium.
So meanwhile, I have opened the conjunctiva on both sides. Inserted the infusion cannula. This is, by the way, the new Dork Avita system, valved cannulas. And to have the infusion connected, that's also a novelty. You don't need to take off the cap anymore. So you can just disconnect it. It's called a push fit system, and it just locks on the cannula without having to remove the valve, which also has an advantage is that during surgery you can always switch to another side if you want. For this surgery, I've installed my working cannulas, my instrument cannulas, more towards the vertical axis than normal, because I want to have here exposed sclera, to make my flaps afterwards to implant the Carlivale IOL. I just filled the anterior chamber with methylcellulose because there was, as I explained, still ghost cells in the eye, and that will give me a clearer view on the posterior side. So I'm now switching to core vitrectomy. I always start by removing the anterior hyaloid first. On the screen, you see an overlay my core vitrectomy settings. So I'm using a relatively slow cut speed now of only 5,000. I work in vacuum mode, and the vacuum it rises to 150 millimeters of mercury. This provides me a quick way to debulk most of the vitreous from this eye. So I always make a few rounds behind the IOL to begin with.
And Peter, your infusion setup is usually at 40.
Usually the infusion will be on the left eye at 4 o'clock and in the right eye at 8 o'clock.
Now, no, what I meant was the infusion pressure. Is it
infusion
usually
pressure? Yeah.
Is it
Infusion
usually
pressure, for now I'm using automated infusion compensation. So now when I release my foot, you see on the left infusion drops to 20. So that's the baseline pressure in my eye. When I increase the vacuum, I can show this by pressing down my foot pedal. While I'm increasing the vacuum, you see that the IOP rises 26, 30, and when I press all the way down, it's 40. The reason for that is I need to compensate for the increased outflow out of the eye from my vitrectome. And with this automated infusion compensation, you can keep the eye pressure constant. This is a, let's say, non-intelligent system. It just increases the pressure as the vacuum rises. Soon the new vitrectome will arrive, the Veloz vitrectome, which has a higher cut rate, but also the possibility to use smart IOP. And with smart IOP, which you now can already use in the anterior segment, but not yet in the posterior segment, the infusion talks to the aspiration to keep the eye pressure entirely stable during your surgery. But that's a coming future, which I cannot demonstrate yet, unfortunately.
We'll come back to you. Thank you, Peter.
Sure.
Let's go to room 4 to Ernesto in Belgium.
I don't know if you noticed, I took the forceps and I pulled away all the vitreous that was remaining here. It was really attached to the retina, so I took the forceps and I pulled it away in order to free it from the retina. And then I put the machine in this shaving mode, which I can really go very, very close to the retina. I also use self-indentation because I think it's the best way. And I'm really, the goal for me in the surgery is to have no vitreous here whatsoever. So even with the forceps or with the scissors, in any case, I really need to remove all the vitreous here because that's where the PVR will come. So there was a line of vitreous holding all these holes. In fact, now the retina is way more mobile than before. And I think it's a tricky maneuver, but it's mandatory. I don't know if you saw it while you were talking to Peter.
Ernesto, what is the... Go ahead.
Ernesto, what kind of silicone oil are you planning to inject?
I use normal silicone oil. I know you love Densirone, but I don't use it much. Unfortunately, some times ago, we spoke about it. I had quite a few inflammatory cases. So I think normal silicone here, if you release all the tractions, will be enough. Would you use Densirone, Klaus?
I think I would, in such a case, I would use Densirone because there are more tears or defects in the inferior quadra and in the inferior retina. And moreover, you have a perfect with Densirone. The patient is lying in a supine position during the day for 8 hours. And within these 8 hours, you have a perfect pressure on the macular area also, which is of course a positive effect only of Densirone. Yeah, with the normal silicone oil, the macula is not usually tamponated or has no pressure force to yeah. So I think
theoretically I totally agree with you. If I have some density in the room, I might give it a try for once. And then maybe review my position. I don't know. Let's see. The other thing I did, I also removed the PVR scaffold which was there. You see now the retina also here is free. Anyway, now I'm going to go into an air exchange and see how the retina behaves under air. And then we'll do the laser and we'll see what I might put density on. Let's see.
So, Ernesto, you do the laser on the air, not with perfluorine?
Never with perfluorine. Klaus will explain you why. No, because I use that much perfluorine in any case. This is my thing. Give me the light. I never use perfluorine above the holes because I want to avoid going the perfluorine under the retina. And in all our retinal detachment cases since 2014, I only had one case of perfluorocarbon retention. There was a little hole, and by doing this maneuver, the perfluorine went under it. So I do the laser always under air. I mean, a long time ago, I went to visit Klaus. He was also doing like this, so I got it from the master. And I'm very happy with this technique.
So let's go to room 1 now, to Fabio.
Yes, I'm fixing the buckle at 50 millimeters.
And why do you use 15 millimeters, Fabio?
Because it's the best distance to protect all the vitreous base. In this case, the eye is full of perfluorocarbon, so I maintain the same pressure, and the buckle is not tight at the end. It's just fixed to the eye wall, and you will see that there will be a good indentation. So I don't have a sleeve to tie the buckle like in the 2.5 band. In this case, just only fix every quadrant, and then I check the retina at the end.
What kind of a suture do you use for?
This is a cardiac seal. Cardiac seal is the suture that I always use in these cases.
This is a sponge-like material, yeah?
Yes, it's a sponge. Yes, it's a sponge.
Why do you prefer this?
Because the indentation is better than the solid silicone oil, the rigid silicone oil.
Fabio, you have a 5 millimeter sponge.
Yes, oval.
Why don't you take the opportunity to put the anasymmetric back?
The what? Sorry?
Okay. To put the surface asymmetrically to block the break. If you have a 5
But because this
break
break is very posterior, so I think that the buckle, the idea of this buckle is not to block the break or to cover the break, but just to protect the vitreous base from PVR. So to decontract the vitreous base. That's why I don't want to put a buckle, because the break is very strong. Another option was just to put Densiron without the buckle, but in this case, if I only use Densiron, I cannot protect the upper part of the eye. So in these cases, the buckle, the idea of the buckle is just to decontract the vitreous base, not to close the break, because this break is too big.
Do you usually use silicone elements or sponges for this kind of a buckle?
No,
sponges.
I like
this one.
This is a good question. I like silicone more because when you at the end of the surgery or coming to the end, then you can tighten it. Whereas here it is, in my hands at least, it is difficult to tighten it so that there is an equal tightening in each quadrant. And therefore, I never use sponges as an encircling element.
But you use the 2.5 band.
I use a 2. I think I was incorrect. Yeah, my band is not 3 millimeter, but my nurse gives me 2.5 millimeter.
2.5. 2.5, in my opinion, is too small for these cases because it doesn't protect all the base, and sometimes give the space between the indentation and the retina to create a PVR space.
Yeah, well, but I think my primary aim is not to have a broad buckle, but a shortening of the equator.
I think when you do a vitrectomy, you are already removing the traction on the brake. So the goal of the buckle in this case is mainly to support the vitreous space.
Yes, yes.
Not really supporting the brake.
But
No
one
matter-
comment more, I think there is a certain revival on buckling or on combined buckle and vitrectomy. 5 years ago, no one spoke of, or almost no one spoke of combining vitrectomy with a buckle. It was, no trend at that time.
Allah, you want to make it?
Yeah, what is the desired height of the buckle, Fabio?
Sorry, how?
What is the desired height of the buckle? You need how much indentation with the buckle seen from inside?
The indentation is you cannot with this buckle you cannot decide how much to indent. You just fix it to the high wall, but the indentation is very large. It's not too big, it's not too strong, but it's very large and protect all the vitreous base. That's why I like it. And I use this kind of buckle even for buckle surgery without vitrectomy, because it protect all the vitreous base and it takes all the breaks. And it's very easy to teach to the others. I agree with Klaus. I never combine buccal vitrectomy surgery, never. I always said, why I didn't do a buccal with vitrectomy.
So let's go to room 2 now. And I would like to thank our panelists. We're going to move to our second panel now. I would like to ask Dr. Afci, Dr. Ghazi, Dr. Aldibi, Dr. Oshima, and Stanga to join us on the new panel. And let's go to room 2 now.
Yes, this is room 2. Can you hear me?
Yes, we don't have you on the screen yet, Peter. Now we have you on the screen as well. So can you walk us what you're doing now?
So I did the core vitrectomy and I proceeded to shaving. Since there was a lot of blood remnants stuck in the peripheral vitreous, I wanted to clean it out, and I'm showing you how I do shaving. The Doric light fiber has this plastic cap over it when you take it from the package. That plastic cap is not just for protection, it's actually to indent the eye. So I reinstalled the plastic cap over the light fiber, and I can use this now to indent the eye. My light intensity I've increased with the foot pedal to 45, and you can see with the Artivo microscope how well you can see my my indent and the blood remnants which are stuck to the pars plana here. This is the way how I always do peripheral shaving, for example, in retinal detachment.
So Peter, you do not use chandelier light, is that correct?
No, I'm just using, so in my right hand, I now have this, the intraocular light fiber, but on the outside of the eye, fitted with this plastic cap. Maybe I can just show this to you. You see, so this is the light fiber, and it's fitted with this protective cap, and so you can use the sideways illumination to indent the eye and to show you the periphery. Because of the high light sensitivity of the
So let's go quickly. I got to interrupt you, Peter. Let's go quickly to room 3. I think Peter is finishing up. Just to ask Peter in Germany. Peter, can you hear us?
Yes.
So can you tell us, we missed the... Yes, now we
Hi.
have you. So tell us what you did.
Yeah, I've waited a bit, but I will show you. I think at the end, the inside was not good under air, and the lens was a little bit opaque, so the vision was not very good. I finished it in a mediocre way. I can show you what happened is that it's possible to stuck the middle like this. The edges were outside of the pit, so it was not completely inside, but the inner part was in it, and it was quite stable after releasing the PFCL and exchanging it to air. It was completely stable, but still there is a certain risk to lose it once the gas, the long-term gas, is resolved. What we learned is that bimanual is a little bit better than monomanual, although in most cases monomanual is successful. The second is PFCL seems to be advantages, but in fact, I didn't succeed more because this result now we had 15 minutes ago under air as well. And under PFCL, the manipulation was simpler, but it didn't help to stuck it more in the pit compared to air. These are basically the messages.
Any comments, Klaus?
Well, Peter, the patient was 64 years of age and he gets a cataract, of course, anyway. And I think during surgery already, and you mentioned it, there was a loss of visibility and a loss of maybe clarity of the lens. So you have to have a situation where most probably in the near future you have to do a cataract operation. And I really think in my hands, why not do a combined surgery?
Yeah, you're absolutely right. I think so too.
You are such a fantastic anterior surgeon, and you do so many cataracts. So I don't well, to be honest, I don't understand why you combined this.
Yeah.
Peter,
you're
question
right.
for you.
I didn't want to bore you.
Peter, assume if this is dislodged, what would be your next? What would you do next?
This woman, compared to children or young adults are more successful, and they all have also a quite stable vision for a very long time. But with 64, she has a lot of RPE changes with long-term persistent subretinal fluid. I'm not sure if I would go for another revisional surgery.
Yeah.
Thank you so much. Do you think heavy silicone oil or perfluorocarbon tamponade for a short period would help to keep the membrane in place and to have it integrated?
Very good question, but both PFCL and silicone oil are not my first choice in those cases with an open optic pit, because both liquids can migrate until the brain. It has been shown with silicone oil even in non-optic pit situations, and this was the reason. So it came from the audience. The idea is good with the PFCL, but I only use PFCL once I have stuck the amniotic membrane and occluded the pit before, and then to stuck it more, and then it can be used with PFCL. But I don't like to use PFCL in a completely open optic pit, and the same is for silicone
We
oil.
have one quick question for Paolo, and then we're going to move on to the next one. Paolo?
Peter, very skilled surgery. Congratulations. How small can you go with a plug of? I think you use 3 millimeters. What's the smallest size you have used?
3 millimeters. I mean, this is a handful cases with this technique. 3 millimeters is what I've used. I can only say that 4 millimeters is too large. Maybe I will shift next time to 2.5 millimeters. But again, I want to occlude this pit. It doesn't help if I put a very small piece in this pit, but it has no occluding plaque effect.
Thank you, Peter. Fantastic surgery. And thank you from Germany. Thank you. Let's go now to Belgium, to Peter Stelman. Peter?
Okay, I've completed my vitrectomy.
Let's go to room 2.
I did a 360-degree indentation to remove all the peripheral vitreous. I applied some peripheral laser. That's a routine of mine, as you may know, to avoid postoperative retinal detachment. And now I'm proceeding to the lens surgery. I've been working with the Carlevale IOL now for a couple of months, and I've did a lot of mistakes. And so The technique that I will use today is combines everything that I've learned for this lens.
Peter, how far posterior do you go with your incision?
Well, this is a flap that I'm making, and it is my intention to install the lens with the haptic through the pars plana. The lens is actually designed to install in the sulcus, but I've noticed that if you make an incision to end up in the sulcus, that not infrequently you can touch the ciliary body and have it hemorrhage, or even worse, detach the ciliary body in that location. So that's why after talking also with colleagues during the past event that we had in the Netherlands last weekend, I've switched now to implanting it in the pars plana. So I'm making two L-shaped flaps here, that Christian meisje. And I will measure 3 millimeters from the limbus, and that will be the area where I will have the haptics from the IOL come out of the eye.
And by the way, for the audience, if any questions, please write your questions on a sheet of paper. Somebody will be collecting them so we can ask the surgeons.
I used to work with pouches, but with pouches you don't see exactly where the IOL is coming out of the eye, so I have no control. So that's why I'm working now with these L-shaped incisions, which will allow me better to see exactly where the IOL haptic will come out of the eye. And such L-shaped flap is quite easy to close afterwards. So instead
Let's
of
go to
making...
room 1 now, to Italy. Fabio?
Yes.
Thank you, Peter.
Zeg je?
I'm almost at the end of the surgery.
So the area that Fabio, you laser on the buccal, is that correct?
Yes, I laser on the buccal. I already had a fluid air exchange because I always laser under air in order to stabilize better the retina. And you see the indentation is good. I think this is the safer way to fix this retina.
Very nice buccal. Fabio, what kind of a tamponade agent do you use in this patient?
Densiron. Densiron for sure, because it's an inferior break. Like Klaus, I like Densiron. It will be removed in less than 2 months. And I had very, very few cases, or maybe no cases of inflammation. As you see, that it works very well. It was very well.
Koros is laughing, but he thinks we are together and are a strong promoter for Densiron.
No, it works. The problem,
accidentally.
surgeons are scared, in my opinion, for the removal of Densiron. That is not easy.
Exactly.
Because so there is a technique. Mario Romano knows it very well. And there is a technique, and if you follow the technique, Densiron removal is quite easy. And Densiron stabilize the retina and inferior retina like no other oils, even with the buccal.
Sunir, how would you do this in the US?
So we don't have Densitron in the US, so we'll end up using regular oil.
Would you use oil in this patient, or would you use citriate gas? This was a retinal rhegmatogenous detachment without PVR.
Oh, sorry, this wasn't the case with the inferior
This
star
was
fold.
this was just a retinal detachment, large inferior break, and no PVR.
Oh, with large inferior break. No, then in that case, I'd be comfortable doing C3FA.
I think that's one of the differences between more in the US versus Europe. We use a lot less silicone oil. Obviously, we don't have.
What was your positioning for the patient?
Face down for a week.
How long?
1 week. Patient never does it a week, but we tell them
1 week face down. Yeah. This is incredible in Europe.
I agree. I agree. It's a torture.
So in such case, without PVR, actually, in my practice, I prefer long-term acting gas like C3FA, like 12%, and face down exactly as you mentioned. So, but this patient is some different finding, like it's very vitreous space is very posteriorly, and it odorizes PVR because of the same problem. Maybe silicone oil is good choice in this patient. But what last question about the Densiron? So in my practice, when I use Densiron, I see inflammation, loss of inflammation, also PVR proliferation on the superior part of the retina. So anyone who is using Densiron, so
Klaus is the expert.
Any inflammation.
I have a patient, I put Dancerone, I think in October. He's a businessman and he is traveling a lot and he couldn't, usually I exchange it to gas or to whatever after I remove it anyway after 4 weeks. I never had during the past many years, 5 years perhaps, I had problems with more inflammation than I expected with normal silicone oil. So I know these arguments, but it's unknown to me. Although there is only one manufacturer, I think, in the world who produces Dancerone, so it could not be that you have another source than me.
So, Peter, can you walk us what you're doing now?
You're talking to Peter Stalmans?
Peter Stallman in Belgium.
Okay. So I've luxated the IOL. By the way, Klaus, regarding your heavy silicone oil, Baugenamp also has a heavy silicone oil. It's called Oxane HD. So there is a different one. Frankly, I've used it. It emulsifies a lot and gives a lot of inflammation. So I would not recommend it. Over
Peter, are you concentrating on your surgery or what we are discussing here?
But I'm an atypical male. I can do 2 things at the same time. So I've luxated the IOL into the anterior chamber. As you can see, the surgeon who did the cataract surgery was a very messy surgeon. There's, I think, half of his own lens is still in the eye. So I've now used this Donnefeld system to hold. I will show you. So this is a combination of 2 forcepses. This one is to grasp the lens tightly at the 90-degree angle, and this forceps is used to cut the IOL. This forceps is strong and has these little nicks in the blade, so the lens doesn't slip out when you cut. That's quite convenient. So I made a 3mm corneal incision. I've cut the lens in 2 halves, so normally it should be possible when I grasp.
What kind of an instrument is that, Peter?
We call it the Donnefeld. Can you show me again? I'm not sure from which brand it is.
And who makes it?
Here. I can look it up for you. So let me see. It's from Catena. There's a reference number. So it's a set of 2 instruments. I really like them. Just be careful that you know the type of IOL you are removing. I recently had a PMMA IOL, and I tried to cut in, and I broke my scissors. So that's well, that was an expensive cut. But you see these other lenses. This is a yellow, I think Acrisof, if I recognize it. It's very easy to cut with them. Mag ik me een drisdeel geven? So now I need to take out the second half of the lens. So I will first put it in a position where I can grasp it.
So let's go to room 3 to Germany again. To Peter Zerman. Peter, you're studying your second case?
Yes.
Can you explain?
Did you have a look on the OCT? This is a case of a macular fold after quite successful retinal detachment surgery 6 weeks ago. The retina is attached and stably attached, but it has a macular fold exactly under the fovea, and it's exactly at the border of the former retinal detachment. So the only chance to resolve these very tricky folds, which are visually quite disturbing, is to do revisional surgery as fast as possible. Which means after more than 2 months, in most cases, it's not possible to resolve it, at least to my experience. So now 6 weeks after surgery, we are doing it, and we do it by ILM peeling to remove any traction epiretinally, and subretinal BSS via 41 gauge cannula to lift the retina again, and with PFCL, we try to massage this fold off.
Klaus, you have a comment?
Peter, one remark on your organization and your team. The changing time is between the 2 cases. It's fantastic. May I come to you and operate for the rest of my life in your team?
I think Klaus is emphasizing German efficiency.
Thank you, Klaus. I see smiling faces of all the team.
So, Peter, this was a fovea splitting detachment. Why do you think this patient got the macular fold?
Yeah, it's a good question. This happens once or twice a year, so it's rare, and I have no certain pattern. Maybe you can discuss it in the board. Sometimes it happens, sometimes not. I cannot say why.
Did this patient position face down after surgery?
No, this was a nasal or temporal break, and she had a posture according to the break, and the break is closed. Das Mikroskop funktioniert nicht. Nochmal weg.
We can go now to room 2 to Belgium.
Okay, so I'm ready to insert the new IOL. Now I will place 2 dots at the correct site where I will extract the haptics from. First, I need to prepare an instrument. I need to prepare 2 instruments. Kunnen mij een inserter geven? First is to make the incision to extract the haptic of the lens. I want to make a 23 gauge incision, de naaldvoerder. So this is the trocar inserter from the cannula. This is 23 gauge, and so I will just bend it a little bit so it makes it easier for me to make this incision. That's one instrument custom designed. Dan mogen mij de 27G forceps geven, die gele. And second is to enter into the eye from the nasal side with a straight instrument may be difficult. So this is a disposable Dork 27 gauge ultra peel forceps. And the nice thing is, and I'll try to show you, if I have to grasp the haptic of the IOL, it has in its forceps these very tiny grooves. And so these very tiny grooves give you enough grip to extract the haptic from the eye. But these are not big teeth, so the teeth will not stick into the lens material. But I need a bend forceps to do this in an easier way, so I just pre-bend it myself. I do it like this. I'm sure the dork people in the room will now start to faint, but I don't care, frankly.
This is off-label, by the way.
This is off-label use. This is off-label use, definitely. Yeah. Don't overdo it, otherwise it may not slide anymore. And also, even you try to do it with a slide bend, it will reduce the opening of the forceps. So I always, after I did this, I will test it and see that it still properly opens and closes. So this is my Carlevale implantation forceps. Good. So now we have to determine the correct site to do this. So I use a pen. Increase a little bit my pressure. This flap is not the most beautiful I've ever created, to be honest. Okay, the passer op 3 mm. Now we will use a caliper to show the 3 mm mark. Ik ga u een deppertje geven als je zelfs op de bodem van die flap even wil deppen dat die droog is. Ja. So I will hold the flap open. That's good. I have a very good resident to help me.
So let's go to OR3 now to Germany. Peter, I think, starting to peel the ILM.
Yes, can you see the macula forward? Wait a second, I penetrated. Yeah, so it's going exactly through the fovea, and we have stained it with dual blue. And before subretinal fluid, we start to peel. Sometimes it has already been peeled, but we don't peel regularly in every retinal detachment. Also, sometimes it might be useful afterwards, but we don't do it regularly.
What instrument are you using, Peter?
The end gripping forceps from Dork, it's a Eckert forceps, Klaus. Of course, the most used retinal surgical instrument, I think, worldwide.
Peter, you don't plan to use subretinal BSS injection to detach the macula?
And maybe I was misunderstood. Yes, we do peeling, and then after that we do BSS subretinal injection via 41 gauge cannula, also from Dork, and then put a PFCL bubble to massage this fold away, hopefully.
So I think we have Fabio here.
Yes.
Fabio, can you hear us? Great. So we're going to continue watching Peter's surgery while we are interviewing Fabio. Fabio, fantastic surgery.
But I'm happy. I'm happy because I gave you 2 points for discussion: the combined surgery and the Densiron, and the surgery went well. So I can travel without any suspense now. I can go back. I can go to the airport happy.
And how long do you plan to keep the Densiron in the eye usually?
1.5 months, like 6 weeks.
And then any tricks you use to remove the Densiron? Because as you pointed out, it sometimes can be challenging. Any tricks?
Yes, you have to use a short cannula and just push attach the cannula and insert the cannula into the Densiron, elevate the eye pressure to 60 and push the pedal and never remove it. Because if you stop to push the aspiration, the Densiron goes down, and then if a bubble goes down, it's very difficult to take it. But it's not difficult. Once you learn the tips, it's very easy.
Thank you for the beautiful surgery, and we know
See
you
you
have a
tonight.
flight to catch, so see you soon here in Cairo.
Thank you to all the team, my nurses, my surgeons, my friends, everyone. Thank you very much.
Thank you, Fabio from Italy. Thank you. So we are back here with Peter Sherman from Germany. Peter, can you center the? Yeah, that's. There you go.
Yeah. So we have also a certain gliosis. We have an irregular staining, so it's not only pure ILM. There seems to be also a glial reaction. So you asked me why this happens. Of interest is that to my experience, it happens only in those cases, not where the macula is completely off, but in those cases where the macula or the retinal detachment just approached the fovea, but the detachment or the macula is not detached. And now I can see that the central part has been peeled already during previous surgery. We will see it with a wide angle visualization in 2 minutes. I just extend the peeled area to show it better.
As you pointed out, these are usually superior fovea splitting detachment. And then the patient usually doesn't position, and then the fluid collects under the fovea.
I noticed that many surgeons now peel the ILM not with the help of a plano-concave contact lens, but under the wide angle viewing. I think at least half of the surgeons whom I looked and watched during the past 2 or 3 years, they do it. They don't use a contact lens. I still use it, and I'm glad that I see it here also. Even my wife does not use a contact lens, but sometimes there is a small, when the first grip is made, the first, traumatizing the retina. So I stick to my contact lens and my high magnification. What is the opinion of the panel and of the audience?
So, Ramsey?
I use contact lens only in myopic patients, very difficult in this patient, but except this, I use 90 diopter eyeball system to heal ALM in regular patients.
I use the Artivo and I use the high magnification lens, but I don't use the contact lens.
Yeah, I use contact lens on all my cases. I flip back and forth, and I'm really convinced that the definition you get with the plano concave contact lens is unbeatable. I have one comment regarding the fold. It's most common in patients that have superior bullous detachments bisecting the macula. And one trick I learned from Carlos Mateo, he positions the patients for the first 30 minutes on the side of the tear, hoping that the tamponade will push the remaining fluid outside through the tear and then position them face down. So that's what I do in such cases to try to prevent a fold.
So I think we're going to go now to Peter, room 2 in Belgium. Peter, we are coming back to you now. Wait, actually, Peter, wait, I want to watch Germany.
Okay.
Peter, you're going to wait a few minutes.
I'll wait a few minutes, no problem.
Peter Sherman, go ahead. So you are injecting the subretinal fluid now?
Yes. And I see that the fold already opens. This is, until now, it's a very advantageous course. In most cases, it's so stiff that it's, even in the detached retina, it's not unfolded, and it's not completely unfolded, but already there seems to be a releasing effect.
This looks beautiful.
So I can,
what do you do after this? Do you do any tampon? What kind of a tamponade agent do you use, if any?
yeah, first I try to release it completely with PFCL with some manipulation. We will do it in 3 to 4 minutes. So you can go to Peter and come back. So I will use more fluid. So we need a high detachment far beyond the borders of the fold. And then I refill PFCL.
Sounds good. I guess in live surgery, you get 50-50. One difficult surgery, one easier surgery. So this came out very nicely, Peter. Let's go to Peter Stallman in Belgium.
Yes, okay, I'm about to implant the Carlivale IOL. So I made 2 flaps. I made marks 180-degree apart at 3 millimeters from the limbus. Unfortunately, because of the waiting, they smeared out a little bit, but I know where I have to be. So this is the pre-bent trocar inserter. Again, this is off-label use. Now I will insert it oblique through the pars plana into the eye. That's a tip. Do this immediately prior to the installation of the IOL because this incision will close rather quickly. This is the injector containing the lens. I've mounted the lens upside down into the injector. And that's also something I figured out. If you inject the lens like this with the bevel down, the T-shaped haptic of the lens will point downwards and it's more difficult to grasp. So I've mounted on purpose the IOL upside down in the injector, and now I'm rotating my injector 180 degrees, so it faces up the fine pincet. So this is my customized forceps. That's the ultra peel, which was bent. So now I'm ejecting the lens, and you'll see that there's this T shape pointing towards my forceps. This is the T that I have to grasp, but in the correct direction, which is like this. It's always a little fiddly. I got it. Now, no, I don't got it completely. Let's try it again. It has to be in the forceps. There I go. Now, before you start pulling, very important, first inject completely your IOL. If you don't do that, then you will rip off the T from the IOL. So I drop it into the inner chamber. Yes. Now, Saint-Martin. So you see, I'm grabbing the T-shaped edge of the lens. So now I will gently start slowly pulling. That now the T will come out, and now I release it. Now sometimes you pull too hard, such as here. In that case, you see a little bit too much of the haptic has come out. Don't try to push it back, but just go to the other side, insert it here, and it will automatically redraw. If you start pushing it back, you enlarge this hole, which is not necessary. So now I make with the again with the bent trocar inserter, I make the incision on this side, again 3 millimeters, oblique into the eye. And now I use another forceps, the groene. Yeah. This is the, I have to think, the 23 gauge SHA forceps from Dork, which I will use to grasp the IOL. Here. Now I can pull back, I have to be careful not to grasp into the iris, of course. I can pull back the T-shape. Now you see why a pre-bent forceps is easy, because otherwise I would get stuck with the nose of the patient. So now I can grasp it from the other side. Okay, I release it, the forceps immediately releases. The teeth are not that heavy that they stick into the IOL. Again, I've encountered all difficult things, so I hope I know now how to avoid them. Gently, gently, gently push it out. Okay, a little bit too far again. Okay, that's good. So you see the T shape here, and here mocht men nog eens de 23G forceps geven, de groene.
Peter, you do a great job on explaining and describing how you are operating.
I'm just a little frustrated that I overpulled it on both sides. But okay, we can correct it. So I'm grasping the IOL again. So you really need two forcepses to do this. One to pull. So that's also important.